Hello and welcome to Season 2, Episode, what is this? 21, Episode 21 of the Physician Assisted Exam Review Podcast. This week we're going to be covering, we're going to start with, we're going to be introducing conduction disorders through the heart. All right, welcome aboard. My name is Brian Wallace. I'm the host and creator here at PhysicianAssistantExamReview.com and the Physician Assistant Exam Review Podcast, which you're listening to right now. This week we're gonna continue with our cardiovascular cardiology discussions. We're gonna pick up with conduction disorders. We're gonna talk a little bit about conduction through the heart in general. We're gonna start off with a little bit about atrial conduction issues. And I think that's probably what we're going to wrap up with today. This stuff can be kind of confusing. I spent more time than I expected to going back through old books and old notes, trying to wrap my head around some of this stuff and make sure that I understood it super, super clear before coming to present it to you. One of the books I have that I absolutely love, it's one of the few books, when I graduated from PA school in 2007. This is 10 years. So, and one of the few books I still have is the EKG book that we got, which is I think it's called The Only EKG Book You'll Ever Need. Hang on one second. Okay, I'm back. I just paused it and ran and grabbed my copy of the book. Yes, it's The Only EKG Book You'll Ever Need by Malcolm Taylor, Thaleer. I have the 4th edition here in front of me. I don't even have any idea where they're at now. I'll put a link on the website to that book. It's really fantastic. It does a great job describing all the issues that you come across and making sure everything's nice and clear with this kind of like stories and things that really help you to understand the information, not just sort of memorize everything, which has always been my standard. I always prefer to understand what's happening as opposed to memorizing. I've never been very good at memorizing, but if I can understand it, I can hold on to it pretty much forever. And then I can use it moving forward. So that's a great book for studying EKGs, for going through things. Another really good website I came across while I was doing this is called lifeinthefastlane.com. Really good, really helpful, great examples of EKGs, great explanations. It's definitely too detailed for us, for what you're going to need for your PANCE, for your PAN-RE, but it's really well laid out and has everything you're going to need. So right now, I'm going to link to the site from my site so you can find it there. But I find that whenever I do that, all the links break and down the road, it causes me nothing but headaches. But either way, it's called lifeinthefastlane.com. Check it out. Definitely a good resource. I am not going to be posting EKG examples on the website. Anywhere I would get them from, I'd have to be just stealing them and posting them, which I really don't want to do. So I'm not going to have specific EKGs on the site. We'll describe them, we'll talk about them, we'll go through things. But for examples, there's so many places to get examples on the internet at this point that you really don't need to get that from me. You can find that just about anywhere. You go into Google and type in ventricular rhythm EKG and you'll get images of that. So it's really ubiquitous. It's easy to find. So I'm going to skip that on my site, but you'll be able to find that in lots of places. Okay, let's... what else did I want to talk about? I think that might be it. So let's go ahead and get started talking about conduction disorders. We're going to start, as always, with our priming question. So here we go. Is the sinoatrial node found in the left or the right atrium? Is the SA node found in the left or the right atrium? Take a guess. In the right. What is the normal firing rate for the AV node? The atrioventricular node, AV node. What is the normal firing rate for the atrioventricular node? Remember, we have the SA node and the AV node, 40 to 60 beats per minute. In what heart rate range would you consider paroxysmal supraventricular tachycardia? In what range would you consider paroxysmal supraventricular tachycardia as a diagnosis? 150 to 250. And we'll talk about all of that stuff in detail as we move forward today. Now, like I said, I'm gonna split this section up quite a bit and chop it down. I have a couple personal reasons for doing that, the experiments I'm trying to run with the show, But in addition to that, I just think this is a complicated section, and to listen to it is even more complicated. So I'm going to make sure that we understand each step as we go and make sure everything's nice and clear as we go and give you time to digest it. So we'll start with conduction, the conduction system in general, and then I'll move on to problems with it. And again, my goal here is to get you to pass your exam. It's not to get you to treat people in cardiology. It's not to get you to be a rock star in the ER. It's to get you to pass your test. And when you get questions, when you're out on your rotations, to be able to answer them. That's really what I'm shooting for here. So with that in mind, the depth I go into, the detail we cover here is all from that perspective. Okay, so yes, I'm leaving things out. Some things I'm leaving out 100% on purpose. It's a depth that I think is appropriate for what you guys need to know for your position, for what you're expected to know, and what you're going to have to answer questions on. So again, the conduction system of the heart can be super complicated, right? There's lots of different things, and we'll get into some of it today, and then we'll get into more detail as we move along and some problems with it, and in subsequent sessions. But I just want those of you who are specifically in cardiology not to freak out as I'm skipping things. It's done entirely on purpose in this section and in pretty much every section we do. I try to whittle this down to just what will be best for you for the PANCE, the PANRE questions on end of rotation exams and on the floors. And when people ask you questions, that you'll be able to answer them and sound like you know what you're talking about. All right, so we'll start with the sinoatrial node. So the SA node, or the sinus node, as it's also known as, or the pacemaker for the heart, right? So this is located in the right atrium. It's a group of specialized cells that generate an electrical impulse which travels through the heart, causing it to beat. So, right, so these are our cells that will cause an electrical impulse. It's a little area of cells in the right atrium that causes an electrical impulse to shoot down through the heart, gets the atria to contract at 60 to 100 beats per minute. So the normal rate of the SA node is 60 to 100 beats per minute. And it's important that you keep that in mind as you go through EKGs. And it's something easy and something you probably already know, but a normal heart rate, 60 to 100 beats per minute, that's how frequently the SA node fires. A normal sinus rhythm is between 60 and 100 beats per minute. Straightforward, simple stuff. From there, so the impulse is created initially in the sinoatrial node. It then travels through the atrium and then hits the atrioventricular node and then is delivered to the ventricles. Again, can be delivered much more complicated than that. That's all we're doing today. We like nice, simple, easy. From there, it goes through the atrioventricular node, or the AV node. This is the place that electrically connects the atria with the ventricles, right? So this is where the signal passes through, kind of like a gateway or a bridge between the atria and the ventricles. The AV node on its own, without impulses from the SA node, from up above, it will fire 40 to 60 times per minute. So if nothing else tells it what to do, and it's left complete, so if you chop apart the heart and you have a top and a bottom, right? The top is the atria, the bottom is the ventricles. On the top, you have the SA node. On the bottom, you've got the AV node. If you separated it, the bottom part would beat at 40 to 60 beats per minute all the time. Because the SA node fires first, it beats at 60 to 100. So the SA node captures the whole heart within that 40 to 60 beats per minute. So the AV node rarely fires on its own unless there's a problem. So a ventricular rhythm is between 40 and 60 beats per minute. Because again, the AV node will fire 40 to 60 times per minute if not acted upon by an external stimulant. So if not acted upon by the SA node, that's what it'll do. An arrhythmia is an abnormal heart rhythm. So a normal heart rhythm starts with the SA node firing, atria contracting, impulse passes down and through the AV node into the ventricles, and then the ventricles contract. An abnormal heart rhythm is an arrhythmia. This is often a result of an abnormal impulse or impulses. So if we get something other than the SA node firing, so just random tissue in the heart shooting out a signal. If you get the SA node firing too quickly, if you get the AV node firing too quickly, if you get a loop, so the AV node keeps firing over and over and over again, or the SA node does that, or you get multiple sites in the heart outside of the SA or the AV node firing. All of these things are possible. All of these things can happen. All of these cause arrhythmias. If you have, so abnormal impulses generated anywhere in the heart can cause this. Another thing that can cause arrhythmias is poor conduction of normal impulses through the heart, right? So if myocardial infarction is something that can cause an arrhythmia, patients who have had an MI can wind up with an arrhythmia because what happens is the electricity is conducted through the path of least resistance, right? We don't have to know much about electricity to understand that. It always wants to go through the path of least resistance. That's why when you're bovying in OR and you wear rubber gloves, you're unlikely to get a shock. Wear 2 pairs of rubber gloves, less likely to get a shock. It's always going to travel through the path of least resistance. If the heart tissue has been damaged, the conductive activity of the tissue changes. So if the heart tissue is damaged, it may be more difficult for the electrical impulse to pass through. So then the electrical impulse is going to go around that tissue, and it's going to screw up the normal conductional pathways through the heart. And you get electrical impulses traveling in all different directions instead of in the straight lines that they're supposed to. All right, so SA node, AV node, and the reasons why we can get things screwed up. You can either get weird impulses from weird places, or the tissue that's supposed to conduct the impulses is messed up. Okay, those are our 2 issues. Those are our 2 ways of getting arrhythmias. So we can split things up a couple of ways, and this is what took me a long time going through these notes. There's several different ways you can look at the issues with arrhythmias with conduction disorders. I'm going to start with supraventricular arrhythmias. Okay, so things that happen above the ventricles. So mostly we're talking AV node and atria here. I'm sorry, SA node and atria here. The impulses originate above the AV node. So this is supraventricular arrhythmias have the impulse occur above the AV node. So if you recall, the AV node contracts at 40 to 60 beats per minute. If we're above that, we should be happening faster than that for our rhythm. It also means that we'll have a narrow QRS complex. A wide QRS would indicate that the ventricle is leading the charge here. It's the one who's having the impulse and it's firing first. A narrow QRS would mean that the atria are firing first. So a supraventricular arrhythmia is going to be concentrated in the atria. It's going to have a narrow QRS. So we'll start with sinus bradycardia. And I'm assuming you know your PQRS, T intervals, and all that stuff. I'm not teaching a whole session on EKGs. That's not what I was planning on doing. I'm hoping you have some basics down by the time you get to me. And this is a review session as opposed to a straight teaching session. And you have some basics down for EKGs. We'll break them down a little bit as we go, but not a whole lot. So start with sinus brady. Brady equals slow. Okay, so less than 60 beats a minute is sinus bradycardia. Right? Our 60 to 100 is considered normal. So anything less than 60 is considered bradycardia. A sinus bradycardia will have normal P waves and a narrow QRS and a rate less than 60. This is easy. You should make sure that you get this right on any test, on any exam. Super, really easy. Rate less than 60, normal P wave, narrow QRS. Another one that's pretty easy, sinus tach. Tachy equals fast. So we're talking about what was our rate? Was 60 to 100 is normal sinus rhythm. So greater than 100 beats per minute is tachy. So narrow QRS, normal P waves, sinus tachycardia. Let me just add that to my notes. The normal P waves and a narrow QRS, but a rate greater than 100. Okay, so this is easy to get. This is like super common, right? Not everyone's going to get sinus brady, but if you go outside and go for a jog, you're going to get sinus tachycardia. Not necessarily an arrhythmia, but a specific rhythm, right? So if I was running yesterday, which I actually was, again, for a change, I had taken a break for a long time, and now I'm trying to get back into it. It's amazing how quick that disappears, but what did I do? 2 miles yesterday. I was doing half marathons not that long ago, and now I'm at 2 miles, and my heart rate was up around 135, 140, and I felt like I was going to die. So that's sinus tachycardia. Completely normal. Normal P waves, narrow QRS, greater than 100 beats per minute. The next one we're going to cover, and I want to go through this a little slow, and it's probably going to be the last one we cover for today, is paroxysmal supraventricular tachycardia. This is on the blueprint. I actually pulled it up to make sure because just the way that these are classified is kind of strange, and I wanted to make sure it was really clear. So you can get supraventricular tachycardia, simply could be sinus tach, right? Supraventricular tachycardia simply refers to above the ventricles, which is what we're talking about. You get a narrow QRS. Tachycardia is greater than 100 beats per minute, right? So a supraventricular tachycardia could be sinus tach. It could also be paroxysmal supraventricular tachycardia. I'm going to stumble through a lot of these words. You're just going to have to laugh at me and bear with me. But there's a lot of things that could classify supraventricular. In fact, supraventricular tachycardia could also be a flutter. It could be a fib. It could be all kinds of things where you have the focus on the atria and you have a tachycardic, right? So it's a little difficult to process. But paroxysmal supraventricular tachycardia is a little bit different. So PSVTs, again, narrow QRS, tachycardia above 100. So, but in this case, it's usually 150 to 250 is what you're looking at. The term paroxysmal means like a spasm or a seizure. So what you've got is a spasm of supraventricular tachycardia. So a little short, usually short, kind of burst of this. And there's a quick onset, and it often stops quickly as well. This can last a couple of seconds to a couple of hours if untreated, but it's that quick onset and then disappearing, which is where it gets that paroxysmal supraventricular tachycardia from that name. It took me a while to understand that. I'm not sure I ever really got it when I was in school, but that makes a little bit more sense as to what this particular syndrome is about. And there are lots of ways you can wind up with this. There's lots of ways you can get this. But the one in particular that is most common and they talk about the most is you think of it like a short circuit through the AV node. And you get an electrical impulse that enters a re-entry loop. So if some of the tissue is damaged where the AV node would normally send out its signal, instead of going out, it actually comes back around and propagates itself. So you get this self-propagation through the AV node, increasing our rate to 150 to 250, and it just keeps going and going like that. In clinical presentation, these patients are going to come in with palpitations, dizziness, some chest discomfort, really common cause of palpitations. On an ECG, you get a narrow QRS, because this is supraventricular. So the AV node is sending the signal back up instead of sending it on. A narrow QRS with a rate between 150 and 250, which we said, and the P waves usually get lost in the fast QRS. It becomes so quick that you can't see the P waves anymore. They're there. They may be, just depending on the type, the P waves may be different shapes. They may be changed, but typically they're lost in that QRS. You don't see them. They're, what's the term? Buried. They're usually buried in the QRS complex. And one of the reasons I think the test pushes these, or at least they're still on the blueprint the way they are, is because the treatment stands out. It's easy to ask test questions on these. It's something people remember, and it's something you can ask about. And the treatment for this is vagal nerve stimulation, right? So we do our carotid massage or make them do a Valsalva maneuver. And that will hopefully that will break the PSVT and send them back into a normal rhythm. Again, super easy to ask a test question on, so I really like this one. And it's a rhythm I think you should be able to identify because it's so easy to ask questions about. So let's talk a little bit about vagal nerve stimulation so that this makes sense. Again, I'm not a big fan of just pure memorization. I'm more a fan of understanding why something happens. The vagus nerve signals the SA node to slow down. Okay, so it signals the SA node to slow down. So when it's stimulated, it slows the rate of the heart rate down. In this case, that's not the main function to help break PSVTs. The main function is it also slows conduction through the AV node. The vagal nerve causes the AV node to conduct signals at a slower rate. The two ways that we can get vagal nerve stimulation, the first is carotid massage. And what you're going to do there, and this is, I don't think you're going to get a question on this, but man, it's again, just so easy to write questions on, and so easy to remember. I want to run through it. You're going to have the patient lie down, first of all, right? Because we don't want anybody passing out. You're going to listen for bruits. You're going to make sure you don't hear anything in the carotid arteries because you don't want to cut off the circulation to their brain. The same reason why you don't want to do carotid massage on both sides at the same time. You have a little old lady and you do carotid massage on both sides and she's got 95% blockages on both sides, and down she goes. So again, that's why she's lying down. That's why you check for bruits first. I also came across where it said that you start on the right side. It's more effective. I didn't even bother to look into why that is. I just sort of read through it and marked it down here. Again, it seemed like an easy test question, although I think it's probably not something you'll see. So you're going to lie the patient down. You're going to start on the right side. You're going to listen for bruits before you do anything. And then you're going to do gentle pressure over the carotid artery at the angle of the jaw for 10 to 15 seconds. And hopefully this breaks them out of it. And it has to do with causing the pressure sensors. There are pressure sensor cells in the carotid arteries. So it makes the vagus nerve think that your blood pressure has gone up. So it responds by sending signals to drop blood pressure. And the one way it does that is by slowing the SA node and slowing conduction through the AV node. So that's why it works. The other one is to have the patient do a Valsalva maneuver, which again just increases pressure momentarily. And it fools the vagus nerve into thinking that the pressure's gone up. So it starts to send signals to drop things back down. So carotid massage or Valsalva are one way to break a patient out of PSVTs. All right. Again, because this is just kind of wacky and hard to understand in a purely audio version, I'm going to quit there for today. We're going to do our post questions in a little bit that'll help reinforce this. And next week as we move on, I'm going to keep repeating things. I'm a big fan of repetition, of spaced repetition. I think that's really the way to go about things. So I'm going to break this off here, and then we'll come back to it next week. We'll review some of this stuff, and then we'll continue on from there. All right, that sounds good to me. Okay, let's talk about our study tip for today. Not exactly a study tip, but something I wanted to talk about, something I got an email about earlier this week, which was a very common question I get to the website, which is, I know that you're in surgery, something along these lines. I know that you're in surgery. How did you go about getting your first surgical job? How did you get hired? I hear you need experience or no one will take you. You can insert any specialty you want, surgery being the most prominent, but you could say dermatology, you could say, I don't know what else, pulmonology, cardiology. No one will take you without experience. This is a very common complaint. So I think it's just anything that people are nervous about or concerned about or worried about. They say, how can you do it without experience? And one thing I want to point out is, people with experience are great. It's nice to hire someone with experience. But on the other hand, there's a lot of advantages to hiring a student, and this is not lost on employers. Some simple major advantages to hiring a new grad. Number one, they're cheap, right? They cost less to hire than someone who's been out for a few years. There's a group that I'm very familiar with who loves to hire new grads, mostly because they're cheap, which I think is a great reason. It gives you a good opportunity and gives them a great resource. The other thing that's nice about new grads is they come in very excited, willing to learn, and very moldable into your practice, into the way you do things. They don't come, it's great to have people with experience come in and bring new ideas and new thoughts, but it's nice to have somebody who's new and excited and wants to learn, and you can train them to do things pretty much exactly the way that you want them done. So there are a lot of people who love to have new grads for those two reasons, and it's great reasons to hire new grads. There are other positions where they say, we need 2 years, we need 3 years, we need 5 years experience, or we won't accept anyone. That being said, if I were interested in the position, I would apply no matter how much experience I had, even if I was a new grad. I would absolutely send in my resume. Now, they may ignore you and not bring you in for an interview, but they're just trying to weed out people and to get someone who's the best fit for them. So your resume gets you to the interview. So you send in your resume, and as long as it depends on how many candidates let's say they get no candidates who submit for that job, except for you, and you have no experience. Do you think they're going to call you in anyway? Of course they are. Why wouldn't they? You don't know what's going on in that environment. So it's always worth submitting your resume. And then your resume should get you to the interview. And then the next most important part is once you're at the interview, as long as you're someone that people want to have on their team, that you're willing to learn, that you're eager, that you can show that you're a normal person that people want to spend their whole day with every day for, 40 hours a week, every week, 80 hours a week, whatever it is, that people want to spend time with you, they're going to overlook your lack of experience if you are a good fit for the team. To me, if I'm hiring, yes, I'm going to look at the resume. I'm going to look at the person who's got 6 years experience, the person who has 0 experience, and I'm going to lean toward the person with 6 years experience. But as soon as we get to the interview, that kind of changes a little bit. And I'm looking for the person who I think is a good fit for the job and who I can spend the most time with. So the resume and the interview are two totally separate things that do two totally different. They have two different jobs. One's to get, the resume is just to get to the interview, and the interview is to get the job. To present yourself as someone people want to work with, someone who's going to learn, someone who's going to be a good member of the team. So you can see the reasons why a new grad would easily be able to compete for a lot of positions. When I've had my first job, I worked with a foot and ankle surgeon in orthopedics. They had no problem hiring a new grad. In fact, that group hires tons of new grads. Where I'm at now, I do multi-specialty, so I do a lot of different surgery, work with lots of different docs. They really aren't looking for a new grad because it's a tough transition to go from no surgery to all over the map. Versus in a private office where you're doing one type of surgery, you can learn it relatively quickly. Not super quick. It took me probably a year. But without that base, it would be a lot harder to do what I'm doing now. So, this particular position, they probably wouldn't interview someone who had no experience, but you know what? You send in your resume. They get no candidates, they'll still interview you. And if they don't, that's okay too. And any opportunity to go in on an interview, it's stressful. It's a big pain in the butt. It is a great experience. It's a great learning experience. Don't get the job. That's okay. Don't walk away saying this was a waste of time and a failure. Absolutely not. You learn a ton going on in interviews. So please don't ever be discouraged by that. And of course, the one of the best ways to get a job as a surgical PA or any kind of PA is to do a good job on your rotations. Get to know people. Networking is huge. It's the biggest reason to hire someone. If you have 2 people and one of them you either know or someone says that person seemed like a good guy or a good girl and seemed like they did a good job and were interested, that person's got a huge head start. So talk to people on your rotations. Show up. Do the job. If you want a job in surgery, look for a surgical rotation where you might want a job. Do your elective at a place where you might want a job. Talk to people. Get to know some people. Talk to the docs. Talk to the staff. Be part of the team, be interested, and always be learning. So I would not be discouraged in the least if I were a new grad trying to get a job in surgery. I had no interest in anything else but surgery when I went to PA school. That was it. I was not doing medicine. We're covering cardiology now. I loved cardiology as a student. I thought it was incredibly interesting, loved it. There is no way I would practice cardiology. Just me personally. I just think it's not something I would want to do. I don't think I've never wanted to practice medicine as a practitioner. I love it to learn about it as an intellectual exercise. I think it's a lot of fun. I think it's I just really like it, but I would not want to practice medicine. I like surgery. That's what I always wanted to do. That's what I went to PA school for. I had no problem getting a job out of PA school. Zero. I think it's a non-issue. I think it's something that people set up in front of them so that they have something to worry about. So they have something to be concerned about. So they have an excuse if they don't get a job. They can say, I'm a new grad. I don't know if I should bother to apply. Apply. Go through the steps. Put yourself out there. Assume you're going to get it. Don't go in weak and meek because you're a new grad. People want new grads. I started a discussion in email last week on this topic, and I got some great responses. I just wanted to read back through here a little bit to this. It just sort of helped me to express my sentiment. And again, I don't mean to say every job is going to accept a new grad. They won't. I told you my job probably wouldn't, but lots of them would. Here's one response I got this week talking about hiring new grads. As for getting a job, I've been in the surgical department for the past 38 years in several different hospitals and for private individuals. I'm now at the large hospital training. I'm training a new grad that just got the job yesterday. Really no surgical experience, but the right attitude. I think she'll do fine. Thanks. Another one reads, this is from Aaron. I was a new grad back in 2013 who saw a job opening for general surgery, and I pursued it. I'm so glad I did. I was the first PA they hired in the practice, and we're now up to 3 PAs, and we prefer new grads, all in capital letters. She goes on to say, I precept lots of students, and I find lots of them have the attitude that they don't want to go. We'll talk about that part at a different time. that was just talking about people who don't want to go into surgery because they don't want to specialize too soon. I don't want to get into that now because we're already running longer than I wanted to. We'll talk about that at a different time. She goes on to say, you're right. If someone has the right attitude and the work ethic, they're easily moldable and trainable. I'm happy to have them on our team. And she also goes on to say, I'm enjoying your emails. Thank you so much for taking the time. That's I've just been putting out a ton of information through the email system. If you're not on there, please go ahead and get yourself signed up. Head over to the website, www.physicianassistantexamreview.com. There's a couple places where you can join. I'm trying to make that a little easier. Right now I've got it sort of broken, but it'll get better. But right on the main page, there's a couple places, and I can't recommend doing that enough. I've had a ton of fun recently, really increased and been sending out daily tips and information on all kinds of topics that I've been getting a great response from people on. So definitely go check that out. Whew. Okay. So the bottom line is, if you are a new grad or you're thinking about surgery, my vote is go for it. Always, always, always go for it. There's no reason to hold back and think, geez, I don't know if I should apply. Always apply. I don't care, what the position is, apply for it. The worst thing that'll happen is they say no, or they just don't return your phone call, or they don't respond. Who cares? No big deal, no loss. All right, let's go on to our post questions. Does paroxysmal supraventricular tachycardia have a wide or narrow QRS? Does paroxysmal supraventricular tachycardia have a wide or narrow QRS? Did I talk long enough to get you to forget? But if you think it through, it's supraventricular. Narrow. Of course, it has a narrow QRS. Does the vagal nerve speed up or slow down the heart? Does the vagal nerve speed up or slow down the heart? Slows it down, right? People pass out. We say they've gone vagal when they're in the OR and they pass out. It slows it down. What's the normal firing rate for the AV node? Normal firing rate for the AV node, if it's not acted by another impulse, acted on by another impulse. Normal firing rate for the AV node. 40 to 60 beats per minute. All right, sweet. That wraps up our introduction to the conduction system through the heart. Like I said, we will definitely be revisiting this part as we move forward. Make sure that you understand exactly how all this stuff works. You'll be able to get these questions easily right on your exam and actually be excited to see them on your test, if you can believe that. These will be things that you definitely want to see, that you will say, wow, I'm so glad that this is on my test because I'm going to nail this one, and then move on quickly. Again, if you haven't signed up yet, head over to the website. I've been doing daily emails with tips and all kinds of information. Definitely go check that out, www.physicianassistantexamreview.com. Congratulations to everybody who passed their test this week, and good luck to anybody taking it this coming week. We'll talk to you soon when we continue with conduction disorders, and I think we're doing atrial flutter, AFib, and we'll see what else we get to next week. All right, everyone, take care.